Hi, everybody. Welcome to TCT wrap-up interview. In this interview, we are going to discuss about the key issues and important issues about the bifurcation PCI. I'm BK Gu from Seoul National University Hospital, and my co-moderator of this session is Shao-Liang Chen from Nanjing, China. And we invited the expertise in bifurcation PCI area, Dr. Andrejs Erglis, Dr. Mamas, and Dr. Imad Sheiban. So hi.
Hi.
Okay, so that we are going to discuss mainly three topics, which is quite high in terms of bifurcation PCI. First, we're going to talk about the side branch intervention issues, focusing mainly on 001 lesion. And then we're going to shift to the DCBUs, and then finally we're going to talk about the left main PCI. Having said that, I'd like to ask to Dr. Mamas about the 001 lesion. You did an expert presentation in the previous session, and also you did a very nice studies for this kind of very unique lesion subset. Can you tell us something about the 001 lesions?
Yes, so 001 lesions are not that common in terms of PCI. So we ran the e-Ultimaster bifurcation registry of 4,000 people undergoing PCI for bifurcation lesions. And the main finding of that analysis was that around 3% of patients undergo PCI for isolated side branch lesions, that's 001. Now, many people will say that isolated side branch lesions are benign. But rather surprisingly, from this registry, what we reported was that actually in terms of target lesion failure, cardiac death, ischemic events, they are the highest risk lesions. They have almost double the event rate of true bifurcation lesions such as 111. So I think one has to be very mindful around approaching these lesions and really think about, number one, the indication, and number two, if you're going to treat the most optimal strategy that will try to reduce the risk in these cases.
So with that rarity, so do you think that the angiographic assessment is enough when we encountering Medina 001 lesions, or may we need to do additional investigation for that?
So I think we have to take a step back and think, why are we doing PCI in the elective setting or in the ACS setting? I guess in the ACS setting, we all understand the reasons. In the elective setting, though, we mainly do it for symptom benefits, and there's a lot of data to say that actually in terms of symptom benefit, it's only in those patients where the vessel subtends greater than 10% of the myocardium. We have data from cardiac CT as well as other non-invasive data, which suggests that the majority of non-left main lesions do not supply 10% of the myocardium. So only about 10 to 20% of side branch lesions do that. And so the vast majority of side branch disease can be managed medically. There are criteria that we can use, and the criteria include a vessel diameter of greater than 2.5 millimeters and a vessel length of greater than 73 millimeters. I think the key thing is to assess for functional significance rather than just anatomical significance, and you can do that in many ways. The pressure wire is the most commonly used modality, but of course you can use other non-invasive strategies such as stress CMR, stress echo, and so forth.
So, Professor Chen, so when you encounter 001 lesions, how do you approach? What is your general strategies in terms of PCI?
Oh, thank you. Thank you very much. I think the real pure Medina 001 bifurcation lesion is very rare. Secondly, even angiographically, a 001 bifurcation lesion is present, but still there are some even mild to moderate plaque in the main vessel. So from my personal opinion, I think firstly, we need to get intravascular imaging to identify the real calcification. Secondly, for real true Medina 00 bifurcation lesion, my first choice, my first standing technique is stop and pull back technique. It means we deploy stent inside branch, another balloon in the main vessel. So during the withdrawal of side stent, we gradually inflate the main vessel balloon. Once you feel very strong resistance, okay, inflate side stent and deflate the main vessel balloon. I think the requirement for stop pullback technique is the bifurcation angle should be greater than 70 degrees. If it's type Y bifurcation lesion, I think crossover is the first choice. Thank you.
So Dr. Erglis, do you have any special technique for treating 001 lesion?
First of all, thank you very much. No, I really appreciate what I seen of Professor Mamas, and it's even we started 20. In our institution, we do around 4,500 PCIs. That means that even if it's only 2 or 3%, this is a quite high number. And we always had this question, what to do, and I'd say that we usually try to avoid the stent, because this was very important what you asked. Actually, how we can, there are two questions. First of all, I guess it's a bit a dogma about this 10% of myocardium. I'm not sure that we have really precise methods to define this. And the second one is what to do. Is it really isolated? Sometimes it's very tight. That means that we can't go with imaging probes through them. And one thing which is really, I think if we can avoid the stent, then it would be good. Otherwise, usually we will finish with 2 stents. Instead, that we actually, but it will be, say later on, what we really use. This is not only drug DCB, but also BVS, what we use for more than 15 years. Yeah.
So Dr. Sheiban, any special tips and techniques for 001 in terms of treatment?
About?
001 treatment, your specialty,
Yes.
yeah, tips and techniques.
Well, actually, I'm trying to do it only by balloon. Of course, need for every time for intravascular imaging in order to define well the extension of the disease, and then decide your strategy. But mainly, I will do it only by balloon. We are using drug-coated balloon today more and more in this subset of patients.
So now we have a very nice concept on 001 in understanding the pathophysiology of this disease, and get to understand that each operators may have a different strategies in approaching and treating these lesions. Having said that, Dr. Mamas, can you share your knowledge on the outcomes of different treatment strategies for 001 lesions?
I mean, the problem is that much of the literature is limited by sample sizes. I mean, we've said that the majority of patients are managed medically, and it only accounts for 3% of cases. Nevertheless, we do have some registry data, both from my group and from other groups as well. In terms of comparison of 1 versus 2 stent approaches, we don't seem to have significant differences between the 2 approaches. There is some data from a DCB registry, again, no comparator, single arm, showing very low MACE rates, acceptable complication rates up to 1 year in terms of follow-up. We simply don't have data around trying to spot stent versus a crossover approach in these lesions. I think the data is just too small to be able to get anything meaningful in terms of outcomes, and I think it's just simply underpowered. My personal approach, as Professor Chen suggested, would be to image. I don't think it's a good idea to try to spot stent invariably. You either end up going too far into the main vessel or missing the ostium altogether. And so if I do have to stent, then I would generally do a crossover. Although, like Dr. Sheiban would suggest, I generally try to use a drug-coated balloon, and in my lecture, that's what I did. I think the key thing, though, when doing DCB is to realise that the ostium tends to be very fibrotic, And so often you don't get good expansion or you get recoil. And so in such cases, I tend to advocate using a cutting balloon or a scoring balloon and then applying my DCB.
Okay, that's great. So that now it's smoothly moved to the use of DCB in bifurcation PCI. So Professor Chen, you did the largest DCB trial in bifurcation, DCB BIF. Am I correct? That study correctly? Okay, so can you explain the rationale and results of DCB BIF trial?
Oh, thank you very much. Basically, from the background, DCB has been used off-labelly in several different kinds of coronary lesion, like CTO bifurcation lesion. So the second thing is that so far there is no powered clinical trial to show the efficacy of DCB for side branch during prominent stenting technique. Our DCB BIF trial only included patients with simple coronary bifurcation lesion, defined based on our definition criteria. Briefly, side branch lesion length less than 10 millimeters, but the requirement was the vessel diameter in either main vessel or side branch minimum 2.5 millimeters. So finally a total of 784 patients with simple bifurcation lesion were included in our DCB BIF trial. The primary endpoint was 1 year tight lesion failure, including cardiac death, charter vessel myocardial infarction, and clinical-driven TLR. By 1 year follow-up, I think the primary endpoint, TLF, was pretty high in the prominent stenting technique with non-compliant balloon for side branch compared to prominent stenting technique with DCB for side branch. But interestingly, there was no significant difference in terms of the revascularization between two groups. We are continuously following our patients up to 3 years. Hopefully we can get more clinical data to support the routine use of DCB for simple coronary bifurcation lesion during prominent stenting technique. Thank you.
Thank you. So that Dr. Sheiban, so can you teach us how we can apply DCB while dealing with bifurcation lesion in daily practice? When and how?
Well, actually, we have been several proposals for the use of drug-coated balloon bifurcation. Many studies have been published, but with very small cohorts. And what we have learned from these studies is that at least it is not inferior. I mean, drug-coated balloon is not inferior to conventional balloon, but it is almost better than conventional balloon. I would say that today, based on evidence-based, I think the only use in bifurcation is in provisional stenting and drug-coated balloon to side branch, which again, I think you will not, of course, harm patient. It is safe because we have a large experience with the use of conventional balloon in provisional stenting. So I think this is the most attractive subset in bifurcation to use it. And I think we have a good rationale also to use it. I don't know if it will be safe in distal left main with long lesion on a side branch. So I think we still need for more support from literature.
Thank you for the excellent summary. I think that any bifurcation PCI discussion or interview cannot be finished without dealing left main PCI. So having said that, Dr. Erglis, can you briefly summarize the current status on left main PCI, one stenting, two stenting, difference between non-left main and left main, please?
Yeah, again, this is, I guess, first of all, which is really important, that what finally we really to get this point, and that we need to use imaging. This is the first, intravascular imaging. Of course, also we seen today quite interesting things about CT scans, which can help us. I guess there is bit steps to go, because we also know disadvantages and so on. But one thing which is really important is imaging. You know, I grow up usually and this is the same with drug-eluting balloons. The first thing is how you prepare a lesion. And this is, I guess, the main point. And then, of course, if you have, first of all, diagnosis, I mean, this is an intravascular imaging, then you can decide what to do. And for this reason, again, it is very important what mentioned Professor Mamas or other guys. Now we have so many new things, not only cutting balloon. I'm not a real believer of scoring balloons. We did a study, but now we have IVL, we have rotablation, we have different kind of new devices. And for this reason, again, I guess it will open us, again, a new era or area where to go. And of course, I'm always very happy, because I like today's discussion about that we should not to go for 1, 2, or 5 years. We should look on 10 and 20 years. For this reason, I mentally still advocated or one-stent strategy, or what we published for your data a couple of years ago, drug-eluting stent in synergy with BVS, and that's allowed us actually to in future, but after really aggressive pretreatment.
Okay, so I'd like to ask all the experts about this very simple question. What is your most common strategy when you do a upfront two-stenting technique? So first, Imad first. Which one?
You mean double stenting in bifurcation?
Yeah, left main bifurcation.
Left main bifurcation.
Upfront two-stenting.
Well, I'm equally using DK crush and DK colot.
Okay, so Dr. Mamas?
In terms of what technique I generally
technique?
prefer. So I'm embarrassed to say in front of Dr. Shao-Liang Chen, but I like Colot a lot more than DK Crush. Anyway, I'm sure he'll forgive me. He's a good friend.
Okay.
I'd say again, it is really depends on anatomy, but I'm also no, I really appreciate DK Crush, but actually I'm also old-fashioned, and I still use, or we use BVS for circ, and or we leave and I try to go for provisional, or actually I use a mini crush. This is what I do.
Yeah. My most common strategy is also a mini balloon crush.
Yeah.
So maybe you don't need to ask to Dr. Chen instead. So I'd like to ask Professor Chen about the session summary of this interview.
Well, thank you very much. I think we have done the full day to discuss the biology mechanism of bifurcation lesion development, as well as the different weapons to treat bifurcation lesion. I think it will be fruitful for our audience, also for our guys on the podium, right? In terms of the corneal bifurcation lesion, even so far, there are many evidence from lab or clinical evidence to show which stenting technique is much better than any another. But I think still there are a lot of issues to do. For example, I think for any given patient with distal left main bifurcation lesion, so firstly we need to evaluate the lesion very carefully, combined with the clinical assessment, particularly with the incorporation of intravascular imaging. I think we will change our strategy anymore. Nextly, I think we need to develop a risk stratification, not only to assess the lesion complexity, also we need to predict the clinical outcome. So far, the existing clinical trial have provided three years clinical follow-up as earliest say. It's not long enough. We need 10 or even 15 years follow-up. I think these are the future we need to do to educate our fellow, to train our junior intervention cardiologists, finally to make as many as possible of patients benefit from interventional treatment. Thank you very much. It's okay? Oh, we're finished. Amazing. Just for cool.
Professional.
Good, good. Good.
Finish now.
Okay.
Oh, it's done.